Kia ora, good evening. Welcome to this webinar on prescribing Isotretinoin for acne in primary care. Tonight I'm joined by Dr Marius Rademaker, who is a dermatologist at Waikato DHB, clinical lead of dermatology, and he will be discussing how some of the common issues with prescribing Isotretinoin, such as effective dosage, duration of treatment, and some of the safety concerns. This webinar is brought to you by the Goodfellow Unit and is supported by FRACP. My name is Miriam Nakatsuji and I work part-time as a GP in South Auckland and teach at the Auckland Medical School. Before I hand over to Marius to get us started with the webinar, I just want to draw your attention to the Goodfellow Unit website and just remind you of some of the CME that's available there. So I'll just take you to goodfellowunit.org. So here you can see an online catalogue of various short courses that you can do online and then print CME certificates from. The top right up here we have the program for our annual symposium, which is happening the end of March, 25th to 27th of March 2017. The Goodfellow events that happen through the year you can also see at this website. And then bottom right, we've got podcasts, gems, and webinars. So if we click on gems here, you can view these on the website or you can get them emailed to you fortnightly. Gems are little practice-changing tips that are based on latest research and are chosen by Goodfellow Director Dr Bruce Arrell. Podcasts you can listen to from your desktop at work, or you can use a smartphone app to do this. They're about 20 to 30 minutes long and it's a good way of fitting in some CME when you don't have much time. We've got around 40 or so podcasts there on the website. We also have a YouTube channel, so if you go to YouTube and just put in Goodfellow Unit, you'll see a variety of different presentations there, videoed presentations from local speakers at the 2016 Goodfellow Symposium. Back to tonight's webinar. So during this webinar, we do want you to ask questions along the way. Because tonight we're actually doing this with me in Auckland and Marius Rademaker is in Hamilton, so with those two different sites, we may probably have most of those questions towards the end of the webinar, but regardless of that, type in your questions as you go and I'll keep track of those and may ask some of them along the way and then leave the rest till the end. So in terms of texting in your questions, you should hopefully see something like this on your screen with an area that says questions where you can type your text and press send. If you don't see that on your screen, then look for a little orange arrow up here because it may just be minimized. You may need to open that up. So any problems with finding that or anything else, you can let us know. We will send you some links and an email after the webinar for feedback as well. So with that, I would like to hand over to Dr Marius Rademaker to get us started, and we'll just hand over to you now, Marius, to take us through your presentation. Thank you.
Thanks, Miriam. Can you see my screen?
Yes, I can see your screen, and hopefully the rest of the audience can see your screen.
Excellent. So what I'm going to talk about is really what we've learned from 30 years of using Isotretinoin, which has really revolutionized the management of acne since that time. And we'll break down to a little bit of history, a little bit of science, and then the rest is just practical stuff. Please ask lots of questions, and Miriam will interrupt me if needs be, if you've got a burning question which needs answering then. So we've had Isotretinoin since 1955. Historically, that's the year that Einstein died. There's no relevance to that, but it helps us put it in place in history. The company was looking for a treatment for psoriasis, and it's not particularly effective for psoriasis, so they lost interest. But in the early 70s, they rekindled the interest, particularly in the scenario of cancer, neuroblastoma, squamous cell carcinoma of the lung, etc. And they also started looking at isotretinoin for treatment of a variety of disorders of keratinization, ichthyosis, etc., and then eventually some acne as well. And this was mostly in Austria and Germany, where the company was based. The first real paper on the use of isotretinoin in dermatology was 1976, the same year that the first Apple computer, now worth several millions of dollars, was published. And 3 years later, in 1979, the first really seminal paper on the use of isotretinoin in acne vulgaris was published. And it took about 3 years to get to FDA approval. And just to show you that things really don't change, this is a picture of parachuting, which is the new mannequin, or the mannequin craze is just a copy of the parachuting in 1982. So the questions which we should be asking 30 plus years down the track of isotretinoin is, what dose clears acne? Is the cumulative dose, which has been so important for the last 30 years, of any relevance? How to manage non-responders, because unfortunately there are some non-responders. How do we manage early relapse? And what's the causality between isotretinoin and the many side effects that are reported with its use? And when I give this talk to Australians, I always ask this question as well. So to put acne in perspective, we need to recognize that acne is changing from what acne was in the 1980s and 70s to what it is today. And probably one of the most important things is our recognition that the prevalence of acne is very different. In the 1980s, 70s, we thought that it was just a teenage problem, but then we started seeing it more and more in young adults in their 20s. And we now recognize that up to 50% of women over the age of 25 still suffer from acne that they like some treatment for. So the clinical spectrum of acne seems to have changed quite significantly. Persisting acne, or acne in older men and women, is divided into two groups. Persisting acne, which is acne which starts in your teens and just persists after the age of 25, and late onset acne, which starts for the first time after the age of 25. And we've tried to distinguish between the two, but in fact, clinically and biologically, they're exactly the same. So there's no particular value in separating these two groups. Our understanding of the pathogenesis has flip-flopped. In the 70s, it was all due to excess grease production. Then it was all due to propionic bacteria, just an effect of the P. acne. But now we're starting to recognize that acne is probably an autoinflammatory disorder rather than an autoimmune disorder. If we go back to P. acne, it's an opportunistic pathogen which does cause medical problems in that it can infect medical devices. It causes dental abscesses, it causes eye infections, but interesting, is also associated with sarcoidosis, and there's a couple of papers suggesting a causal role in prostate cancer. Now, there are 4 main lineages of P. acne and 36 plus species, and what's really been difficult for us is that only 3 of these species are actually associated with acne. So all the P. acne research from the 1970s and 80s, we really have to redo with the specific species that are associated with acne. Now, the inflammatory products of P. acne include tumor necrosis factor alpha, interleukin-1 beta, interleukin-8, and if any of you have kept up the literature in psoriasis and eczema, these are the same inflammatory mediators. Our innate immune response, as opposed to our adaptive immune response, is crucial in the development of acne, and our innate immune response includes the chemokines, more importantly includes antimicrobial peptides and toll-like receptors, and these are all stimulated during the acne process. So our view now is that acne is an autoimmune, autoinflammatory disorder. It has a time course of 5 to 10 years, maybe even 20 years in some patients. And so the principles of treating with 3 months of a course of antibiotics no longer holds validity. And like other autoinflammatory autoimmune diseases, we're wondering whether early aggressive treatment may actually be better. So with rheumatoid arthritis, we have early introduction of DMARDs, disease-modifying agents, and we're thinking along the lines of acne as well. At the same time, the good antimicrobial stewardship is really telling us that we should no longer be using antibiotics in the treatment of acne, either topical or systemic. If you do use topical antibiotics, you must use an alternative agent such as benzoyl peroxide or a topical retinoid in addition, but our preference is not to use any antibiotics for acne. Possibly the biggest change which has happened in the last 30 years is patient expectation. In the 80s, people were happy with a 70–80% improvement with their acne, which is just about achievable with antibiotics, but now they want 100%. And reducing someone's acne from 100 spots to 1 or 2 spots, patients will come back and say, you haven't helped me as yet, because they're wanting 0 acne. Now the only thing which does that are the retinoids, and so here's a bit of the science. Isotretinoin is a naturally occurring retinoid, so if a patient wants natural treatment, there's nothing more natural than isotretinoin. It's in all of our cells already. So it's derived from retinol, which goes through a pathway from a retinol provitamin to retinaldehyde, then to all-trans-retinoic acid. And this is the active component or active compound of the retinoids. Now, up at the top here, I don't know if this is my pointer, it's absorbed through the gut, it's transported to the liver where it's stored, and then it's carried through to the skin cells and other cells, of course. And there it's transferred through a binding protein. Retinaldehyde is transformed, metabolized into all-trans-retinoic acid, which reversibly is metabolized to 13-cis-retinoic acid. And then it gets absorbed, or it gets transported into the nucleus, where it binds onto what's called the retinoid acid receptors on DNA. So there's 2 types of retinoid receptors, RARs and RXRs, and if you're interested in retinoid metabolism, these are very important components of how they work. The short of it is that they affect about 500 genes. 300 of these genes are upregulated, 200 are downregulated. Through the classic RAR, RXR response element pathways, it's about 27 genes. Without the response element, about 100 genes, which means that about 350 genes are affected in means not directly related to DNA. Now, the effects of isotretinoin alter with time. We know it's at least biphasic. It may be more than biphasic. It's just we've only done the studies at 1 week and 8 weeks of treatment. In the first week of treatment, you have upregulation of tumor suppressor genes, protein processes, which is why it's useful in the treatment of cancers. But by week 8, you have downregulations of genes involved with the metabolism of steroids and cholesterol and fatty acids. And you have upregulation of genes that encode for structural proteins such as collagens and fibronectin. So the main function of isotretinoin, or method of action of isotretinoin in acne, is its effects on sebaceous glands, and it induces apoptosis, or natural killing, dying off, and cell cycle arrest of sebocytes, the cells within the sebaceous glands. And this reduces to a reduction in oil production in the skin and changes the whole environment within the pilosebaceous unit. After this, you get a skin which is adopting a gene expression of wound healing, which is why isotretinoin is such a wonderful drug for acne, because acne is often very scarring. Now, this apoptosis of sebocytes is a bit dose dependent. At higher doses, not only do you eliminate the sebocytes, but you also eliminate stem cells and precursor sebocyte cells. And this means that at high dose of isotretinoin, you can get long-lasting effects, sometimes even permanent effects, which may or may not be good depending on your perspective. Now, this is probably the most important slide if we discuss isotretinoin. This is many of its different functions. If we move up, it has immunomodulatory effects. It increases T and B cells. It enhances B cell differentiation, which is good. It inhibits IgE. To the right here, it has anti-cancer effects through the induction of apoptosis and improving cell differentiation. Down below, you have anti-angiogenic effects, which is particularly useful for diseases like rosacea. and then it has a whole host of anti-inflammatory effects, which is why isotretinoin is used in a whole range of other conditions you wouldn't ordinarily think would respond to a retinoid. So to summarize the effects of isotretinoin, it affects over 500 genes. The effects are both time and dose dependent, and at lower dosages you get stimulation of a healing pattern of gene expression, and we're actually now, as an aside, we're doing some studies on wound healing and trying to enhance that with low-dose isotretinoin. And it reduces the inflammatory autoimmune response to P. acne and to sebum. But at higher dosages, it causes long-term sebocyte suppression. Now, the traditional indications, when it first came out, was for severe nodular cystic acne at this dose, 0.5 to 1 milligram per kilogram per day, for a duration of 4 to 5 months. And this 4 to 5 month period was determined by the concerns people had regarding pregnancy. And this somehow got manipulated into a cumulative dose of 120 to 150 milligrams per kilogram. Now, there's a number of dogmas with isotretinoin which need to be cleared up. The first is that you need a dose of 1 milligram per kilogram per day to clear acne. And we need to go back to the history of its development as to why this dose was chosen. So in the 1970s, it was using for a variety of pancreatic and brain cancers at a dose of 2 to 3 milligrams per kilogram per day. So not surprising when in the first studies of acne, they used 2 milligrams per kilogram, and Peck did a dose-ranging study of 1 to 3.3 mg per kg. But the year afterwards, other researchers did a much lower dose-ranging studies of 0.1 to 1 milligram per kilogram. Pluig of Germany did 0.05, and this was followed up a year later by another 0.05 milligram per kilogram. Now, if we translate that to the average 70 kg person, that's 3.5 milligrams per day. This is quite an instructive series of studies done by Bill Cunliffe, a British dermatologist in the 80s. And if we look here, this is a dose-ranging study, 0.1, 0.5, and 1. This is the percentage change in acne grade, and along here the number of weeks. It's a 16-week study, and you can see that the rate of response and the total response is exactly the same between the three dosages. And even after the end of treatment cycle of 16 weeks, patients continue to improve to the end of the study of 32 weeks. In a small study of seborrhea and acne from a German group, they treated 11 patients with quite low dose, 5 milligrams per day of isotretinoin, 2.5 milligrams, and then actually 2.5 milligrams 3 times per week. And they had good results in all the patients. We did, about 4 years ago, did a study on 5 milligram dose of isotretinoin here in New Zealand in adult patients with persisting acne. It was double-blind, placebo-controlled. For the first 4 months, patients either received isotretinoin or placebo in double-blind fashion. Then there was a 4-month open-label study. The inclusions were 3+ facial acne lesions per month for the last 3-4 months. But no more than grade 2 acne. They were not allowed any other treatments. And we did the usual measurements of acne trials, acne lesion counts, the Dermatology Life Quality Index, which is a quality of life measurement, patient self-assessment, erythema scores, patient diaries, and photography. The two groups were evenly matched. And if we look at the results just quickly, in the red are the isotretinoin group for the first 4 months, and you can see within 4 weeks there was a halving of the number of acne lesions, and that continued to improve in the double-blind phase of 16 weeks. Compared to the blue, which is the placebo group, they had no improvement, and in the open-label phase, the blue improved quite nicely in the same fashion as the first group. And the patients who had 32 weeks of isotretinoin had, on average, just 1.5 lesions at the end of the trial period. So what dose clears acne? Well, the answer is that any dose will clear acne, certainly 5 milligrams per day. If you can't get hold of 5 milligrams, although my understanding is we may have a 5 milligram dosage soon. funded through FRACP. 10 milligrams 2 to 3 times a week could be used, and that will clear you completely, and the rate of response will be the same. And it's independent really of the severity of your acne. Probably the lower effective dose of isotretinoin is probably about 2 milligrams per day. The difficulty with 2 milligrams though is there's quite a lot of pharmacodynamic variation depending whether you take it with food or not. So you can have the absorption if you take it without any fat, being a fat-soluble vitamin. Now, a really important part of isotretinoin with any treatment is failure, primary failure, and that is going to occur in about 1 to 2% of patients. Relapse, so the acne coming back after it's cleared, is not a primary failure. That's a secondary relapse. Now, primary failure is not dose dependent, so you can use 8 milligrams per kilogram per day, or you can use 0.1 milligrams per kilogram per day, and you're going to get the same failure rate. And most of those are probably just slow responders. And all you really need to do is just treat them for a much longer period of time, not 4 months, but 12 months, 18 months, 2 years, 3 years.
Marius, can I just... Sorry, Marius, can I just interrupt you there for a moment? So when you say primary failure, at what kind of time course would you be expecting people to improve with their acne? When would you call it primary failure?
Sure. So most people will see a visible response within a couple of months, and generally depending on where the acne is. So the face is usually looking reasonably good at 3 months, your chest is going to take 4 months, and your back is going to take 5 months. So if at 6 months you've not responded, you're likely just to be a slow responder, right. And if you continue for longer, you will respond. So a primary non-responder is someone who's had 12 months of treatment and has really done nothing.
Right, sure. Okay, thanks.
All right, so the slow responders are smokers. You need to examine acne very carefully, so you need good light and you need to touch the skin, and there's an acne lesion we call the macrocomedones, and we know from the onset that these will take 12 or 18 months to respond to treatment. So if you're not aware that these are there, you'll be very disappointed in the response. If you've got something driving your acne like polycystic ovarian syndrome, then you're going to be a slow responder. And for some reason, young age, under the age of 14, often will take half as long, if not twice as long, to respond than someone who's 18 years of age, and we don't understand that. And also if you've got excessive seborrhea, that sometimes takes longer to respond. And truncal acne, if your acne goes mid-back and lower, it's going to take 6-9 months to clear. And this sort of acne hardly ever responds to any other treatment than isotretinoin. So what do you do for smokers? Well, clearly you ask them to stop. What you can do is clearly treat for a year or two, and you've got to manage that. And the way to manage that is when you get them back after 3 or 6 months and they're still not as good as you like to, you give them another treatment like trimethoprim, 300 milligrams per day. And that has an additional anti-inflammatory effect, anti-neutrophil effect, so that may be helpful. Or it may be that you're just giving them a 3-month course of this and you see them again after 9 months and they're just improved with 9 months of isotretinoin. Hard to say because no one's actually done a double-blind placebo-controlled trial of this. For macrocomedones, you can start off with 12-18 months of treatment, or you can speed it up by doing some acne surgery. And there's a number of ways you can do that. It's important not to stop the isotretinoin because you want to try and maximize the healing response and minimize the scarring. For polycystic ovarian syndrome, you can add in appropriate anti-androgens such as third-generation contraceptive, particularly if it has cyproterone acetate. You can do low-dose spironolactone or flutamide. Or if they've got a degree of insulin resistance with metabolic syndrome, some metformin is being increasingly used.
And Marius, sorry if I can just interrupt again. So just with the PCOS, one of the questions that has just come through is isotretinoin less effective in patients with PCOS? So would you say that it is still as effective, but they are just going to take a longer time, and you may need to use some of those, that combination therapy?
Yes, yes to the latter. So you will respond, but it will take longer, and your chance of relapse is a little bit higher because you have something which is driving your acne which you've not switched off.
Right. And I'm familiar with the cyproterone acetate, so Jeanette, I think, is the one that we often use, but what about the flutamide? I'm not familiar with prescribing that. Is that something that, who would prescribe that?
It's probably done more by the endocrinologists. We sometimes use it for anagen-driven hair loss, etc.
Right, sure. Okay, thank you.
So for young age, and the youngest acne sufferer I've treated is 6 months. We do use isotretinoin for congenital ichthyoses, but from acne, 6 months is the youngest I've treated. You can wait for them to grow older, but it's often very scarring in 6-8-year-olds, and you really want to try and avoid that. So you can add in trimethoprim in that group if you wish. For seborrhea, this is the one time where you probably do need to increase the dose of isotretinoin a little bit. 20 milligrams per day is usually sufficient, but very occasionally you need to go up to 1 milligram per kilogram per day for, say, 3 or 4 weeks to really induce apoptosis of the sebaceous cells, stem cells. But you can add in a topical, such as benzoyl peroxide, or a topical retinoid. So you can use a topical and a systemic retinoid in the same patient. Probably the only role for UV or for PDT is in this scenario, because PDT, photodynamic therapy, targets its sebaceous glands. For truncal acne, we know from the onset that that's going to take at least 6 months, and if you tell the patient that, they're usually pretty happy with that. But you can try and speed that up by adding in an anti-inflammatory antibiotic.
And Marius, sorry, just before you move on, yep. So I noticed in a few of those scenarios you recommend trimethoprim. So is this just in kind of preparing for this webinar? I did kind of read a little bit about how tetracyclines are contraindicated in patients taking isotretinoin. So is trimethoprim your preference if you are using antibiotics?
Yeah, so the problem with the tetracyclines is the potential for benign intracranial hypertension, more with minocycline than the doxycycline.
Right.
And at high doses of retinoids, particularly with hypervitaminosis A, benign intracranial hypertension occurs relatively commonly. Now, at 1 milligram per kilogram per day of isotretinoin, there's been a few reports of benign intracranial hypertension, so there's sort of a blanket contraindication of using the two in combination. But in fact, if you're using low-dose isotretinoin, they work very nicely together, particularly in diseases like rosacea, ophthalmic rosacea. So you can use them, but it's probably better in the first instance to use something like trimethoprim. We used to use erythromycin, but the hepatotoxicity of erythromycin and the antibiotic resistance from plasmids from erythromycin is relatively high, so we don't like using erythromycin anymore.
Sure. So from what I'm taking from that would probably be, as a GP, that I would use trimethoprim with isotretinoin if I did need an antibiotic, and
yes,
tetracyclines would probably be something to leave to the dermatologists in terms of working out whether they're appropriate to use together.
Yeah, I think that's reasonable.
Yeah. Just one other question about the PCOS. Someone is asking, would you add that cyproterone acetate contraceptive pill from the very beginning, from the very start of treatment, if you knew your patient had PCOS, or would you only add it in later?
So there's a couple of ways of answering that. One is the only real concern we have with isotretinoin is pregnancy. So we're generally very happy if a patient is on an oral contraceptive.
True, yeah.
Now, the second generation oral contraceptives have very little effect on acne. you probably get the same number of people's acne improving as you get not getting worse. So if you're treating acne with an oral contraceptive, you really need to use a third generation oral contraceptive.
Right.
However, there are high risks with those from the point of view of venous thromboembolism, DVTs, etc. So you've got to need, and increased risk of depression and other sorts of things. So particularly in the 35 plus group of women, you probably don't want to be using a third generation oral contraceptive. Now you don't need that if you're treating with isotretinoin. So we would generally change a contraceptive from a third generation to a second generation if we started isotretinoin.
Right.
So it's a long way of answering your question.
Yeah, a lot of different factors to consider, I can see.
Yep.
Thanks.
So relapse is probably the biggest problem with isotretinoin. And there's this long-standing dermatological dogma that you need to use this really big dose to prevent relapse. And the first thing to ask is what other diseases are managed by cumulative dose to prevent relapse? You know, hypertension, diabetes, all these other diseases, psoriasis, eczema, none have this cumulative dose. So physiologically, it's nonsense and always has been nonsense. One of the problems we've had is defining what relapse is, and the way I define it is someone needing more isotretinoin. And it's a secondary failure of treatment. So this cumulative dose of 140 milligrams per kilogram is both dose and time dependent. So you can give double the dose, 2 mg per kg for 2.5 months, that'll give you 140 mg, or you can give 0.1 milligram per kilogram for 4 years and you get the same sort of dosage. And no one can tell me that that makes any sense at all. This is just a slide of many of the studies which have looked at relapse rate, and I won't bore you with them. What's important is the acne not having cleared by the time you stop the isotretinoin. So if you treat for a fixed period of time, which was the old protocols, a proportion of patients are going to be slow responders. They're not going to clear, and they're going to relapse. It's you know, nonsensical to think otherwise. If you've got macrocomedonal acne, if you've got PCOS, and if you're young age, we know that it's going to take longer and you're a much higher chance of relapse. So if you treat a 12-year-old with isotretinoin, you can clear their acne with 12 or 18 months of isotretinoin, but chances are that you will treat them again when they're 16, and chances are that you treat them again when they're 18. And that's fine, and patients are very happy with that if you tell them right up front that that's the case. And interestingly, women over the age of 30 with late onset acne do seem to relapse much more. And these are people with really autoinflammatory disease which are not altering with just a 3-month or 6-month or 12-month course. What's not important for relapse is the daily dose used or the cumulative dose, the family history, whether they've got truncal acne, whether they're male, etc. Now there is a slight physiological, or quite significant physiological differences between the dosages. If you use 1 milligram per kilogram per day, as I mentioned earlier, you're going to get apoptosis of sebaceous gland stem cells. Whereas with a smaller dose, you're probably not going to get that apoptosis killing off of the stem cells. And the significance of that is with a big dose, at the end of treatment, you're going to remain very dry for at least 6 months, if not a year. Where with a smaller dose, your oil glands are going to recover within 3 to 6 weeks. So what that effectively means is that 6 months of a big dose is about the equivalent of a year of a lower dose, but has nothing to do with cumulative dose. It has to do with how long you suppress your sebaceous glands for. And that physiologically makes a lot of sense. So relapse, how common is it? Well, about 20 to 25% of patients will need a second course, 5% of patients will need a third course, and 1 to 2% will need repeated courses over many years. Under the age of 14, you can expect half the patients need another course, and probably at least a third, if not more, women over the age of 25 will come back to you a year or 2 or 3 down the track asking for some more treatment. And the way to minimize that is to make sure the acne is gone completely and then treat for another 4 to 6 months. but you don't need to use a big dosage. 5 milligrams per day is probably enough, and hopefully we'll soon have that dosage available to us. And make sure that any macrocomatose have resolved and that any residual PCOS is being treated.
And Marius, with that high relapse rate with the younger under 14-year-olds, does that influence your decision to actually treat those young people with isotretinoin?
Not at all. So the thing is, you need to treat and prevent scarring. So you need to treat them as soon as you... The most important indication for isotretinoin is scarring. We should really no longer accept acne scarring. It's hard to say it's negligent to see acne scarring, but it should be medical misintervention.
And so for those younger people under 14, you would just continue to treat them until all acne is gone, and for a further 4 to 6 months, like you say.
Yep. But what we do is reduce the dose to such a low level that what generally happens is they start forgetting to take it, and they naturally stop it themselves.
Sure. Thanks.
So the current use in New Zealand anyway is for nodular cystic acne, for moderate acne, and for mild acne, which is not responded to topical preparations. I'd actually use I don't use any antibiotics anymore. I haven't for the last probably 10 years now. So I go from a topical retinoid, topical benzyl peroxide straight to isotretinoin. Only if you're using a low dosage though. And for negligible acne, and this is controversial from the doctor's point of view, but it's not controversial from the patient's point of view at all, because from their perspective, they don't have negligible acne. They've got quite severe acne. So we've got this disconnect between counting spots and saying you've got 3 spots, you've got negligible acne, you don't need any treatment, to what a patient sees. And patients are now changing, and we need to acknowledge that they want 100% clearance because they see all these Photoshop models on TV with perfect skin.
And Marius, sorry Marius, with the antibiotics, I'm surprised to hear that because a lot of us GPs use oral antibiotics quite a lot for acne. And so is that something that would differ between dermatologists, or is that something that's the trend that's starting to happen?
So in the last 3 or 4 years, we're getting the larger dermatology groups, the European Dermatology Forum, the American Academy, coming out with statements that say we should not be using antibiotics in the treatment of acne. And that's all to do, well, it's due to 3 things. One is antimicrobial stewardship. The second is they don't actually work that well. And the third is cost. The cost of repeated course of antibiotics is substantially higher than a course of low-dose isotretinoin.
So you go from those topical treatments through to low-dose isotretinoin. What about using one of those third-generation contraceptives prior to a trial of isotretinoin?
All my patients are referred, so I have to say most of them have either tried that or don't want to be on it. I have a little bit of discomfort starting adolescents under the age of 16 on third-generation contraceptives for acne. It's just a personal point of view. If they want it, that's fine. But look, I go through all the options with the patients and tell them the results. And they all choose isotretinoin. It's the parents who have the disquiet about starting isotretinoin, and so we often, not often, but occasionally we have to manage the parents more than the child.
Right, and like you say, you are getting the referred patient cohort, which is slightly different to the people that we see.
Yes, of course. Yeah. So within dermatology practice, we see acne in medical patients who are on systemic corticosteroids or immunosuppressants, such as inflammatory bowel disease, etc., which is driving their acne. So isotretinoin is a very effective treatment for that patient group. We'll come back to inflammatory bowel disease as a side effect at the end. depression and acne, if you've got a patient who's depressed, who's got acne, you can be sure that their acne is a major contributing factor to their depression. And one of the best antidepressants you can do is by clearing up their acne, and isotretinoin is probably by far the best way of doing so. Persisting adult acne, there's only one treatment which is effective for that, which is the isotretinoin. And scarring, you really want to try and avoid that. Now, one thing in children under the age of 12 is when you use isotretinoin for the treatment of neuroblastoma, you're using a dose of 2 mg per kg or greater for long periods of time in 3-4-year-olds. And they have reported an early closure of epithelial plates. That's not been reported with standard isotretinoin dosages of 1 mg per kg for acne. But it is something that you need to discuss with them and say the risk for your child is very low.
I think in a child, I don't think many of us GPs would be prescribing isotretinoin.
No, probably not, but you need to know the spectrum of disease which you can treat. We've talked about comedonal acne. We've talked about acne scarring as well. If the acne scarring is established, if it's no longer red, then you're not going to improve it with isotretinoin. So what dose do I use? Well, I start girls, adolescent girls, on 10 milligrams per day, and generally treat them with that for about 3 months. And then if their skin is looking good, and it's usually facial acne, then we reduce the dose to 5 milligrams per day or 10 milligrams 3 times per week and treat for a complete year. And for boys, because they've got more acne on the back, it takes a little bit longer, so tend to treat them with 10 milligrams for 4 months or so, and then continue it for another 8 months again to a total of 12 months. But it depends on the response. You know, if they've still got a little bit of acne after 10 months, then we'll go on for 14, 16 months. For adults, I start at 10 milligrams per day for the first 3 months or so, and then continue treatment usually for a couple of years. And most of them will come back saying, please, can I have some more? And I'm very happy with that. And if we get the 5 milligram dosages, there's some physiological benefit of having 5 milligrams a day as opposed to 10 milligrams alternate days. Certainly much easier for patients to take daily rather than trying to remember which day of the week it is to take the tablets.
So those maintenance doses there, Marius, those are once the acne has already fully cleared and you're then continuing it on for those extra months. Yeah,
you can, I often will reduce the dose before their acne is cleared completely. If you get a 70, 80, 90% improvement in the acne, then you can reduce the dose at that stage. It depends a little bit on how much adverse effects they're getting and what the patient's desires are, really. So we talk it through with the patient and come to an acceptable agreement.
Great, thanks.
So in combination, we've mentioned trimethoprim, which we add for a few months at a time, and we do that for particularly inflammatory acne, for slow responders, for smokers, which are slow responders. Sometimes with the doxycycline, you used to get some gram-negative folliculitis, and so the trimethoprim is a bit useful for that. Minocycline, I do use it, as I mentioned earlier, in combination with low-dose isotretinoin, and we alternate, so we give 50 milligrams one day of minocycline and 5 or 10 milligrams the other day of isotretinoin, and that's particularly useful for rosacea, ophthalmic rosacea. With hormonal therapies, we've mentioned those, and we do that for PCOS and hyperandrogenism. But we also do it to female slow responders who are probably subclinical PCOS. And women who relapse very quickly, sometimes it's worth considering, but you need to take into account, if you're over the age of 35, what are the additional risks of anti-androgen therapy. I use prednisone at a reasonably big dosage for people with very inflammatory acne, mainly because there's such risk of scarring, significant scarring, you want to switch that off as soon as possible. So you're going to get quite a nice anti-inflammatory effect of prednisone, but you are going to get an acnegenic response to the prednisone as well. So you just need to be aware of that. There are certain subtypes of acne which are particularly severe, such as acne fulminans and pyoderma faciale, where we use prednisone, or sometimes other anti-inflammatories such as methotrexate. With surgery, there's been a relatively contraindication for surgery, but that's not evidence-based, and in fact you can do surgery on isotretinoin without too much hesitation, as long as the dose is quite low. And we would do that for acne scarring and comedose, and you can have laser treatment either for IPL, intense pulse light, or FRACP or PDL, and it actually probably improves the end result if they're on low-dose isotretinoin. So talking about side effects, now transient side effects are dry lips unless you knock off the sebaceous gland stem cells. And there are some people who 10 years down the track who took a big dosage still have pretty dry lips and dry eyes. Actinic cheilitis is an interesting adverse effect. It's probably the main reason they stop isotretinoin is because of this actinic cheilitis. They just get very sore, inflamed lips, which is a little bit of mixture of sunburn, dryness, and sometimes some secondary infection. Pregnancy is probably the only adverse effect we're constantly concerned about. Mood change we'll come back to. There's no doubt that isotretinoin causes mucocutaneous side effects, which are entirely dose-related. So at 1 mg per kg, 100% of patients will have dry lips. At 0.1 milligram per kilogram per day, you're down to maybe 10 or 15%, and it's, of course, much more mild. Higher dosages can affect night vision, which is a problem for pilots, and so Civil Aviation Authority have a sort of general blanket ban of isotretinoin in pilots, so you need to discuss that carefully with your patients first. Long-distance truck drivers may need to be cautioned as well, but when you're losing lower dosages that we're now using, the risk, potential risk, that's much, much less. Teratogenicity is the main concern, and at high dosages you do get quite significant musculoskeletal discomfort, which then can translate into sort of a grumpiness of teenage boys, which can be interpreted as mood change. Uncertain is depression, suicidal ideation, suicide. We'll come to data regarding all these in a moment, and inflammatory bowel disease. So there's a very specific teratogenicity documented in 1983, although it was expected right from the onset because it's a retinoid. And this is the features of the retinoid embriopathy. The risk has been reported in doses of 0.5 mg per kg per day, and it's up to 20% to 40% of patients exposed. Just to put into context, thalidomide, the teratogenicity rate was 20%. It's worst at about 6 to 8 weeks of gestation, which is you'd expect because that's the time of major organogenesis. There probably is a minimal dose because isotretinoin is a naturally occurring retinoid, so it's in our blood at any one moment in time. We know that 10,000 international units of vitamin A is safe. The background risk of malformation is 3% of live births, and the background rate of neurodevelopmental abnormalities is probably 5%. The recommended daily intake of vitamin A is 3,000 international units, which is about the equivalent of a milligram of isotretinoin. So 10,000 international units, about 3 milligrams of isotretinoin per day. And you can variety of tests to indicate what the teratogenic dose is, and it's probably about 24 milligrams if you're a 60 kg person. We're using 10 milligrams or 5 milligrams a day, so it's below that dose, but I advise you just not to take the risk. It's just not worth it. There are various prevention programs. The original company, Roche, had the pregnancy prevention program. The FDA introduced SMART and iPledge, which made it very difficult for patients to get isotretinoin. They need to have a monthly pregnancy test. They need to go to their pharmacy with the result of the pregnancy test every 4 weeks to pick up the drug. And it means that patients just don't get the isotretinoin. And a lot of dermatologists in the United States no longer prescribe isotretinoin because it's just not worth their while. Pregnancy rates in the US is about 109 per 1,000 persons per year, and with the pregnancy prevention programs it drops to 9 per 100,000. And we estimate that every dermatologist will have an unplanned pregnancy in one of the patients every 5 years or so. Inflammatory bowel disease was first case report was 1982.
Marius, just before you move on, sorry. So with the heterogeneity, I understand that for female patients you would not rely on the progesterone-only pill. You would ideally want something kind of like a long-term contraceptive and perhaps even 2 forms of contraception.
Yeah, so I'm not paternalistic with my patients. I tell them what the risks are, and we discuss the ways of avoiding pregnancy, and really have to leave it up to them not to become pregnant, because we tell them that if they do become pregnant, the strong recommendation is a termination, although it's not always a given. How you avoid pregnancy, we have a sensitive discussion with the patients, and I do that in 12-year-old girls, and I do it in 60-year-old women, which are probably not relevant in either case, but we still have the same discussion.
And that's for a month or so after stopping isotretinoin as well?
So the half-life of isotretinoin is probably between 12 and 15 hours. So the general rule of thumb is 5 half-lives, and it's no longer a risk, which is between 60 hours and 72 hours. So 3 to 4 days is going to be sufficient. However, patients very rarely know when they become pregnant, so we generally recommend a menstrual cycle between stopping and attempting pregnancy.
And with male patients that you're prescribing for, does isotretinoin affect sperm? Is there any contraception?
No, not at all.
No?
No, not at all. No.
Okay, thank you.
So going to inflammatory bowel disease, which was hit the news about 4 years ago, most of the case reports failed to fulfill the Hill criteria for causality, which is, I've listed the 9 domains of that. And it's interesting that in the United States, 90% of the spontaneous reports to the FDA are submitted by lawyers for claimants rather than for doctors, which tells you something about the American legal system. So there have been a number of case control studies, IBD, inflammatory bowel disease, Crohn's disease. These are the relative risks. You see the confidence intervals all cross 1, so they're not raised, and with ulcerative colitis, not raised either. A different patient cohort showed in 2010 that there might be an increased risk of ulcerative colitis with a relative risk of 4.3. That worked out as the numbers needed to harm of 3,000 patients. Interestingly, the risk of inflammatory bowel disease on any patient on tetracycline is actually raised at 1.4. And not so much for minocycline, but was for tetracycline and doxycycline. So that data made us think that actually there's an association between acne and inflammatory bowel disease more so than there is with treatment. And I'll just flash through these. So there was a repeat of the 2010 case control study using the same database but control for the severity of acne, and we see that the relative risks are all 1, so no correlation.
Marius, we had a question emailed in beforehand actually about whether there was any link with other autoimmune diseases such as lupus. Is there any?
Yep. No, there isn't at all. In fact, we use isotretinoin. If we look at this slide here, if you look to the left there, the anti-inflammatory effects, we would expect isotretinoin to be useful for the treatment of lupus, and in fact we do use isotretinoin for cutaneous discoid lupus erythematosus, as well as sarcoidosis. So good question, so use it with confidence. Thanks. Depression, first reported in 1982, so this was launched in 1982, so it didn't take very long. And when you look at associations, you look at case reports, you need to look at temporal association, you need to do challenge, re-challenge, you need to see if there's a class effect, you need to see if there's a dose response effect, so a higher dose you expect to see more, and you need to have a biological plausible mechanism. Many studies now of depression and suicide associated with isotretinoin. And if you look at the group studies, most show no effect, or in fact an improvement in depression because you're treating the acne. So quite a few psychological parameters increase because of perceived benefits in patients' perception of themselves. But a few studies do show an association with depression. And the rates vary from anywhere between 1% and 6%, and that's an important figure to remember when we'll come to some data about depression later on. Big data studies, the ones, larger studies show no association. One study with 2,000, another with 7,000 patients. The only study which showed associated with depression was much smaller. And interestingly, if you look at where these were published, no association in the dermatology journals and association in the psychiatry journals. If you look at spontaneous reports to the FDA to September 2000, they had 394 cases of depression. Australia and New Zealand, for a 15-year period, we had 136 reports of depression, 37 of ideation, 25 suicide attempts, and 23 completed suicides. And to put that in perspective, we had 68 pregnancies. So is there a dose effect of isotretinoin depression? In a cancer study where they used 3 mg per kilogram per day, in the study they reported that a quarter of patients had psychological changes, but they don't describe what that was, and there was no formal testing, so we don't know how to interpret that. Peck in 1982 used a huge dose, 8 milligrams per kilogram per day in a number of patients and showed no psychological effects. Whereas we do know that the mucocutaneous side effects are directly dose-related in this range. On the biological mechanisms, animal studies are relatively conflicting. Possible mechanisms include people with depression and affective disorders may have increased retinoid receptor activity, and so if you give them even a small dose of retinoid, that may enhance those. There's been discussion as well, there's been a reduction in biotin or an increase in homocysteine. None has been proven yet. There's an interesting study looking at PET-FDG, which measures glucose uptake in the brain, and they compared 13 isotretinoin patients and 15 patients with antibiotics. They compared Hamilton Depression Scale, and there appeared to be a 16% reduction in glucose uptake in the isotretinoin patients. Unfortunately, the groups were not matched at all, as the isotretinoin group had a much higher baseline rate, so it was hard to interpret. And there was no difference in the depression scores, so again it was hard to interpret. Is there a class effect? Well, there's a few letters regarding other retinoids. This is one case report in the British Medical Journal of etretinate for psoriasis, another one for acitretin in psoriasis, but very, very few reports for the hundreds of thousands of patients treated with retinoids for other skin conditions. We do know that hypervitaminosis A, though, causes irritability and mood change psychosis, although it's largely from data from the 19th century, and that was really from very, very super physiological dose of vitamin A. And for a lot of those patients, as I mentioned earlier, they developed benign intracranial hypertension, so they had major headaches, so it's hard to differentiate that from the symptoms of depression. We know that the Arctic explorers who ate polar bear liver, they all went mad. and this well-described condition of Arctic hysteria. The FDA reviewed suicides up to 2000. They had 37, and they would have expected 400, so substantially reduced. Interesting study from Sweden, which looked at a retrospective review, so it's always got to read that with a bit of caution, of over 5,000 patients started on isotretinoin over that period of time. And they had 128 admissions for attempted suicide. And the rate of suicide, admission for suicide actually was substantially higher in the year before before starting isotretinoin, and continued for about 6 months after starting on isotretinoin. And if we look at this graph here, this is pre-treatment, so you can see the risk of suicide, admission for suicide, is on a really quite steady incline before they start on isotretinoin. So it probably is more reflective of depression and acne. But they thought that the numbers needed to harm was about 2,500. But they stated that the risk of attempted suicide was rising before treatment, so an additional risk due to isotretinoin could not be established. There's another what happens in normal populations, not that the Americans are normal, but if we look at the suicidal ideation rates in America in teenagers aged 18 to 29, almost 6% have suicidal ideation, 1.6% make suicide plans, and 1% actually attempt suicide. And so if we look at our figures of isotretinoin, they're actually very, very low. Nice study from Norway was a cross-sectional study of almost 4,000 Norwegians, boys and girls. We know that about 80% of this age group have acne, but 14% had a lot or very much. And suicidal ideation in girls was 25% of those who had a lot or very much acne, compared to 11% or 12% who did not have a lot of acne. And for boys was similar, 22% versus 6%. So this is unrelated to isotretinoin treatment, this is just related to acne. So how we interpret this is that all patients with acne are at risk of developing depression or suicidal ideation, and it's not related to treatment. So all parents should be aware of that risk and advised to seek medical help if symptoms occur. And we encourage monitoring for depression, even if you use a topical preparation. And one of the questions or three series of questions we ask our patients, have you been feeling unusually sad? Have you lost interest in things you were interested in before? And have you been agitated or grumpy or short-tempered? And unfortunately, if the parents are all there, they all shake their head at number 3. So I think that's probably where I'm going to stop and take some more questions.
Thank you, Marius. That's excellent. Can I just, while I ask people about their questions, can you just go back to one of the slides that we've had a few people wanting to go back to? And that was one where you have the dosages with the for the boys and the girls and the adults, with the maintenance number of months and that kind of thing. That would be great.
Yep.
And so for the audience, so if you can just continue to type in any questions that you want answered, and I've already got a few to start off with. Just a reminder, if you weren't here at the beginning, to ask a question. Down the bottom right of your screen there should be a little text box that you can type in a question and press send, and if you don't see it, then look for an orange arrow so that you can open up that text box. So Marius, a couple of questions to start off with. I've got a few people asking about how often would you get people to come back for follow-up, and what about monitoring? Because we've got a lot of stuff that there's a lot of practices have protocols about this, and also we've got the best practice decision support tool from BPAC, and about kind of some of the blood test monitoring that we should be doing at 1 month and 3 months and that kind of thing.
So one of the problems is that the guidelines or the protocols that people have developed are from international guidelines, which are very FDA and the EMA, European Medical Agency, are driven and are not evidence-based at all. So the evidence now is that blood tests actually add no value. They just confuse things. You find abnormalities which you are probably better not finding. So I no longer do any blood tests other than pregnancy tests. I do prefer a beta HCG to a urine pregnancy test. So I do encourage my female patients to have that, but I do not insist on that as we discuss in depth the risks of pregnancy beforehand, and I have confidence in my patients, which maybe is naive of me. But
well, actually, that was another question. Was someone saying, you know, if you've got a young female who promises they're not going to get pregnant or says that they're not sexually active, do you kind of are you obliged to prescribe contraception? But I guess from what you're saying, you just talk to them about those risks and the options.
Yeah, it's all risk management, and so you can prescribe an oral contraceptive pill, but are they going to take it if they don't want to? You can get them to do a pregnancy test, but a pregnancy test is not going to stop them from becoming pregnant. So they are components of a pregnancy prevention program, but the most important is education of the patient to understand why they mustn't become pregnant and how to help them avoid doing so.
Yeah.
Yeah.
And just back to those blood tests. So, what about a baseline blood test? I mean, would you say that isotretinoin is contraindicated if there are pre-existing liver enzyme dysfunction or high triglycerides or something like that?
Almost always no. So there are case reports of, particularly with higher dosages of significant hypertriglyceridemia, but if you do the economic analysis of testing everyone for the very occasional abnormal result, it just doesn't cut the mustard. So yes, you can do blood tests if you like at the start, but the evidence from quite a number of reviews of a large number of patients who've had blood tests done is it does not influence your treatment.
Right.
The lipids do increase, and they increase more in families with familial hypertriglyceridemias. So interesting, it is a bit of a marker for someone who might develop hyperlipidemia when they're 40 or 50 years of age. But any advice you give them at age 15 is going to be long forgotten by the time they become relevant. So I do not do blood tests. I have colleagues who will insist on having blood tests. It's interesting that that usually means that the patients will not take the drug. So we've got quite a few patients who will not take isotretinoin because they have to have blood tests. I think that's a shame.
So it is something that probably differs a little bit amongst dermatologists that you're aware of in terms of how often, whether or not blood tests are done and how often.
Yes. So there are people who adhere strictly to the international guidelines of 1 milligram per kilogram per day for 4 months with review arrangements every 4 weeks with blood tests. And I'm not going to disagree with that, but I think the evidence is quite clear that all of that's quite unnecessary.
Right. And I mean, I'm sure from what I'm aware of in primary care, there are practices that kind of have their protocols just to make sure that all GPs are doing it the same way. And there's the BPAC best practice decision support tool, which a lot of people use. A couple of other... sorry.
You've got to remember that how these protocols develop, and so there's usually a lag period of about 10 years from the evidence finally getting into the protocols. So the protocols are based on what we knew and thought about 10 or 15 years ago. So and things are changing.
Just a couple of other questions I've got here. is there a maximum dose, lifetime dose or duration of treatment, I think? So are there any people who actually need to be on isotretinoin indefinitely, or is there a maximum duration?
So when we use it for the congenital ichthyoses, they will be on it for the whole of their lives. So we've had it since 1982, so that's 35 years some people are on.
Right.
We use isotretinoin for anti-cancer prevention. The other retinoids, such as acetretinoin, are probably a little bit better, but they will stay on isotretinoin lifelong.
Okay.
So no, there's no end point to the need for taking isotretinoin. What we're finding is that, particularly in the adult patient with acne, we're clearing them age 30 with 10 milligrams per day. Then they reduce the dose to 1 or 2 capsules, 5 milligrams, 10 milligrams once or twice a week. Their acne is good, they stop the medication, it flares, 6 months later they start again, and they do that intermittently for the next 20 years. It works very well.
Right, okay. Just a couple of other things. So we've got topical treatments. So if you are starting someone on isotretinoin who's just been on topical retinoids or benzoyl peroxide, do you then continue topicals, or do you stop them?
It does take 4, 6, 8 weeks for the isotretinoin to become effective. At higher doses, when we're using 1 mg per kg, we used to get quite a significant flare of people's acne after about 4 or 6 weeks of treatment, which is due to a combination of stopping the previous treatment, which is often an antibiotic, and the major apoptosis we got in sebaceous cells, which was suddenly releasing a large amount of antigen, which caused a major flare of acne. We see that much less with lower dosages, but we do see it occasionally. So my general rules, it depends on how bad their acne is. If it's inflammatory, I will treat with a trimethoprim and maybe some steroids, systemic steroids at the introduction of isotretinoin. Otherwise, we just get them to stop and just use moisturizers.
Right. And just a little question about the topical retinoids. Although we are focusing on isotretinoin, someone's asking whether you can use it in breastfeeding, because it is. It says
the answer is yes, you can.
You can.
You probably shouldn't rub it onto the nipples, so they don't suck through. But there's no problem. The question is, can you use it in pregnancy? Now there have been 3 or 4 reports of pterogenicity with topical use of topical retinoids. However, the background rate of pterogenicity is 3%, or of birth defects is 3%. So we do not think there's an association. So you will find that some of the topical retinoids have a pregnancy categorization of X, which is not used in pregnancy, but they are probably quite safe.
Right, okay. Alcohol, in terms of the effect on the liver, is there any, can you not drink while you're on isotretinoin?
This is an interesting discussion we have with the parents that are present with the kids. There is no contraindication from the drug point of view. However, it's a great opportunity to get some sensible alcohol advice to these teenagers.
Right.
So we look at the parent when they're sitting next to their child and start talking about alcohol, and we make sure that we encourage them in the right direction of avoiding alcohol. But no, there's no particular concern.
Right. I'm just going to have a little look over at my other screen to see what other questions we've got here. In terms of the lipids, somebody's asking, but I guess we're not, you're saying that you don't test for this, but if the lipids do become elevated while on isotretinoin, is this something kind of temporary, or is it a permanent effect, longer lasting?
Yeah, so when we're using big dosages in the 80s, 1 mg per kg per day, we used to see reasonable increase in lipids, which we never really worried by. The triglycerides, though, were a bit more concerned. Very occasionally, you used to get quite an increase of triglycerides from 2 or 3 to 10, and then the concern there was the possibility of an acute pancreatitis. And there's probably a half dozen case reports of acute pancreatitis in association with isotretinoin and triglyceridemia. Difficult to know whether it's causal or not. Certainly the risk is not big enough to warrant doing tests on the lung.
Sure, okay.
If you do the tests, what should you do? Generally, you use it as advice of reducing alcohol consumption and to sensible dietary advice too. But if the triglycerides have gone up threefold, then you may want to just stop the isotretinoin for a little bit. But
and in terms of the number of visits and follow-up and that kind of thing, what somebody's asking about whether, phone follow-up in between visits and how often apart, that kind of thing. What do you recommend?
So when we started using it 30 years ago, the isotretinoin was the most difficult consult we used to have. We used to spend an awful lot of time. We used to have practice nurses ring up our patients. We used to see them every 4 weeks because they all got dreadful sort of side effects, which they tolerated exceptionally well. Now that we're using lower dosages, we just don't see it. We used to give them skincare packs with lip balms and eye drops and moisturizers and sunscreens and the whole lot. And now there's just very little point in that. So we used to see them every 4 weeks, which is great from the income point of view, but it's really not necessary. And so I now personally tend to see them 3 to 4 months after starting. And then I tend to see them at the end of the course, which is 12 months, to determine whether they can stop or not. So I see them at the start, 3 to 4 months, and then at the end of 12 months.
And I guess for me personally, I can imagine I'd want to see a female patient more frequently. Don't know if that's what you do, but just to make sure and check on the contraception and check on that kind of thing.
Yeah, yes, I think you have to assess every patient, and that's the thing with isotretinoin and acne is every patient is slightly different. So you can't use a cookbook approach. You got to look at the patient, assess their risks, assess their desires, and treat appropriately. So it's quite reasonable to see someone after a month and then maybe at 3 monthly intervals after that. There's no right or wrong. There is what you're comfortable with. I've got a long waiting list, so the way of managing that is seeing them less often.
Sure, yeah.
I do write to every patient after we see them, so the letter includes the pregnancy discussion which we've had, how to manage side effects, so there's that follow-up, and they've got a practice nurse phone number, so they can contact them any time. And previously, when we were using big dosages, they would be ringing every week. Nowadays, it's maybe twice a year someone rings.
Right. I've got a question here, sun exposure. So you would just advise patients about using sunscreens and covering up?
Yeah, it's a great opportunity to talk about sun care. So the risk of, it's not really phototoxic, but you do burn a little bit more quickly. So if your normal burn time is 10 minutes on isotretinoin, it may be 9 minutes and 30 seconds. So it's not a huge difference. But if you're a rower spending 3 hours out on the Lake Karapiro in summer, you're going to get sunburnt. So this is a good opportunity to advise them about sun protection.
Yeah. Got a question here about cutting 10 milligrams in half to get 5 milligrams, but I'm assuming you can't do that.
You can't do it because it's photosensitive, so you can do it in the dark. So when we're using treating little babes with ehrlichiosis, we put it into a bit of butter, but you have to do it in pitch black. But my understanding is that Pharmac may be tendering for a 5 milligram capsule, which is great. You can buy a 5 milligram capsule. It's been available from, I think it's Douglas Pharmaceuticals for a number of years, but you have to pay for it. It's not that expensive. So 5 is probably better than 10 alternate days, but you do what you do.
Yeah. I'm aware of time, so I'll just scan and see what other questions we have. Perimenopausal woman going through menopause with hormonal changes, no problems in using it in those women?
That's the only thing which will work in those women. So in the 50-year-old age group, probably about 20% will have acne, and 10% and half of those will be wanting some treatment for it. So it's an important group of women.
And I probably think we have covered most, and I do apologise, people out there, if there are things that we haven't. Oh, actually, one I can just see here: Sjogren's, patients with Sjogren's.
Sjogren's, okay. So Sjogren's is an autoimmune disorder where you get dryness, particularly of the eyes and the mouth. Now, eyes dry out for a number of different reasons. You've got meibomian glands which sit in the eyelids, so you have tear production over your conjunctiva. Now that evaporates very quickly, so you need sebum, oil from your meibomian glands, to float on top of your tear layer to stop that from evaporating. And Sjogren's doesn't have that, so they've got very dry eyes. So you can anticipate that some of those patients will get drier eyes and it won't be suitable for them, but you have others which will cope with it quite well.
Sure.
Now in rosacea, ophthalmic rosacea, you get meibomian gland dysfunction, and so you get dry, irritable eyes. It's quite common. Up to a third of patients with rosacea will have that. And probably half of those patients will respond nicely to very low dose isotretinoin because it regulates that meibomian gland function. But if you use too high a dose, then you stop the sebum production completely, and that will make it worse.
Great. Well, thank you, Marius. I think we'll probably need to finish the questions there. So thank you very much for your time. I've learned a lot myself, and I'm sure our audience has as well.